Welcome to Adapting Class, and thank you for joining the channel for NCLEX review. We're going to do some case study, next generation mastering, how to approach next generation questions, especially case study. This is a prolonged, elongated case study just to show you some content related to some GI stuff. So let's get to it. If you're new, this is Adapting Class, and welcome. And then hope you learned something from today. This is the first case. It's one case, but it's a lot of it. You have a 45-year-old client present to the emergency department, cramping and colicky abdominal pain and vomiting for 2 days. Client reports nausea, decreased appetite, inability to pass stool or flatus for 2 days. Client underwent emergent appendectomy for ruptured appendicitis a year ago. Deny any fever or chills. Patient on physical exam is alert, oriented times 4. Dry mucous memory, long clear bowel adole. S1, S2 is present, no murmur or gallop present. Abdomen soft, distended, generalized mild tenderness, no rebound or guarding, high pitch, hyperactive bowel sounds, drawing, pain, paroxysms. No abdominal bruit. These are the vitals. Slightly tachy, blood pressure is okay, and then pain 6 out of 10. She has a history of client has a history of hypertension and reflux. When you see questions like that, a bunch of information. I call it the buzzword. Look for these buzzwords. The first 2 lines should give you some clue, right? If you can't figure out the first 2 lines, try to figure out the main. We call it chief complaint. Go for the chief complaint. Why the patient came to the emergency room, and then you'll be able to figure out. There'll be a bunch of information. Not everything is right. But if you find the chief complaint, make sure everything in the rest of the case connects that. We have a 45-year-old. I'm going to align the buzzword, right? Present to the emergency room. Why? Crampy, colicky, abdominal pain, vomiting for 2 days, nausea, decreased appetite, and inability to pass gas or stool. If you can't make a diagnosis here, then you're going to be lost. But don't be lost, even if you can. Keep on trying to connect to that. Otherwise, then you'll be guessing. You should be able to tell me 2 or 3 things that is happening. 45, colicky, sudden onset of colicky, abdominal pain, cramping, vomiting for 2 days, cannot take anything, and then has not passed gas or liquid or flatus. That is your clue. This is buzzword. This is how you do case study. Don't just read and then move on and start to answer the question. Figure it out. Make the diagnosis on your own. Something should be ringing in your ear telling you why this patient is behaving like that. Then, the rest of the information is designed to support the diagnosis. Client underwent emergent appendectomy for ruptured appendicitis 1 year ago. Does it give you a clue, right? Client does not have fever, right? The dry mucous memory, right? And then on the abdominal exam, distended, generalized mild tenderness, there's rebound and guarding, but there's none of them, right? Patient has high pitch, hyperactive bowel sounds throughout the paroxysmal abdominal contraction, during the bowel contracting, right? So that's where you have an hyperactive bowel sound. This is the vitals, and this is the information. You have to figure it out. What is wrong with the patient? What do you think is wrong with the patient? After you figure it out, then you answer the question. But this is the short case. It's not that hard. You have to figure it out, and then you answer the question. Did you figure out what do you think this patient have? What do you think is going on with the patient? Well, I want you to tell me which clinical finding is concerning. Based on what I've told you, does the history of a reflux a problem? Patient has 2 emesis, blood pressure, constipation for 2 days. This you say 2 days. Colicky abdominal pain, high pitch, hyperactive bowel sound, and absence of abdominal guarding. Is that a problem? Pay attention, right? So this is the case that we've talked about. If you have underlying, you don't have enough time to, but you got to slow down, figure out all the key facts. This is the client blood pressure. This is all this information. Figure out which of these you can send it, right? That's the history of reflux. You're not going to do anything about it. You're not going to be doing anything about reflux, so you should not pick it. Patients be vomiting for 2 days. It's worrisome, right? The blood pressure is 130 over 70. It has the history of hypertension. That is fine. Constipation means no gas, no bowel movement for 2 days. This should say 2 days. This is not good. You should not go unless you have bad constipation. Colicky, abdominal pain are never right. Something is wrong with the patient, right? And then high pitch hyperactive bowel sound is also not right. Absence of abdominal guarding. Who think this is something you should worry about? Who think this is something we should worry about? And should we worry about this? Absence of abdominal guarding. Is it worrisome? Sometimes watch for this double negative. Absence of abdominal guarding is basically the patient does not have guarding. Guarding is um, signs of peritonitis. If they don't have it, then that is good. So these are some of the things that, based on the case, you should be worried about. What workup the nurse should anticipate based on the clinical presentation? Do you need abdominal X-ray? Do you need a CBC? Do you need a CMP? Do you need a CT scan? And do you need a blood culture? Tell me, what do you need? Based on this case, how are you going to make a diagnosis? Are you going to work up the patient? What do you need to be able to figure out what need to be done for this patient? This is the case as you have read it. So which of this do you need? Do you need a X-ray? Do you need the abdominal CT scan, CBC, complete metabolic panel, and blood culture? What do you think? And which of this is related? One thing strategy, don't select because it's there. If you know only one, just pick it. If you keep on selecting, you're losing point. Okay. You pick those that you know you can bite, right? But that answer choice you're going to pick should be related. Just because they give you doesn't mean you have to pick everything. So which of this you think the patient we need to do to be able to make a diagnosis? This is the case. Which of this do you need? So what are your answers? Which of this will you do for this particular problem? I can tell you we need the abdominal X-ray. If you need the abdominal X-ray, you should get CT scan. If you get a CT scan, based on the way the patient is presenting it, vomiting, we should get a complete metabolic panel. There's nothing wrong getting the CBC and see if there's any infectious aspect of it causing the problem. So all of this is problem. There's no need to get a blood culture. There's no signs of infection. So this is not indicated. Abdominal X-ray was obtained and shown below. Name two possible diagnoses the net should anticipate. The image shows steep ladder pattern of multiple dilated loops of air and air fluid layers. The colon and the rectum are gasless. That means there's no gas, right? This is what we got on an X-ray. What do you think is going on? Even if you can't read the X-ray, I give you the reading. It's a steep ladder pattern of multiple dilated loops of bowel and air fluid layers, and colon and rectum are gasless. This is what we call air fluid layers. This is it. Air fluid. There's air on top and the fluid at the bottom. This is what it looks like. So all the white stuff is fluid, the black stuff is air. Therefore, based on this X-ray and based on the history that we read, what do you think? Possible diagnosis. Is this small bowel obstruction? Is this acute cholecystitis? Is it gastroesophageal reflux? Is it large bowel obstruction? Is it ileus? Is it acute diverticulitis? Is this pyloric stenosis? What two diagnoses will you pick from this based on this picture? Based on the reading I told you, steep ladder pattern of multiple dilated loops of bile and air fluid layers. In this history, 45-year-old came in emergency room, colicky, abdominal pain, vomiting, no flares, no gas, decreased appetite, as a history of appendicitis in the past. Which of this you think is the possible diagnosis and why we have this condition? This is how you do case study. It's not any magic. You have to understand the question. It's a storytelling, right? So which of this you think is a possible diagnosis? Pick two. I said pick two possible. So pick two, let's see. Two possible diagnoses. You cannot pick a diagnosis without relating to the text of the question, right? The story has to match. So which of those should you pick as a possible diagnosis? I can tell you there's nothing in the case that shows this patient has a reflux problem. There's nothing in the case that shows patient has acute cholecystitis. You should have right upper quadrant pain that go to your shoulder. There is nothing in the case that will make you pick acute diverticulitis. That means we got to work on it and figure out our knowledge on acute diverticulitis, right? So, and then you should not pick pyloric stenosis because the patient is vomiting. The patient is like 45 years old. It's too old to get pyloric stenosis. And therefore, you left with what? Large bowel obstruction, small bowel obstruction, and ileus. Ileus means the small bowel and large bowel is full of air, right? This one in the colon and the rectum has no gas. It can be ileus. So it's either small bowel obstruction and large bowel obstruction. So for each finding below, specify if the finding is consistent with the small bowel. Now I want to show you, this is like a lecture. What are the features of a small bowel obstruction? Abdominal distension, bilious emesis, high-pitched bowel sounds above the obstruction, hypoactive bowel sounds below the obstruction, previous abdominal surgery, colicky abdominal pain, and sudden onset. If they give you any case related to this, what I'm doing today, this is exactly how they're going to ask you. So which of those, if somebody asks you distinguish between a large bowel obstruction from a small bowel obstruction, which of this is consistent with the small bowel obstruction? Small bowel obstruction is the little bowel, right? They start from your esophagus to your stomach, and this is the small bowel before you go into the bigger bowel. So the bigger bowel is the large bowel obstruction, and this is the small bowel obstruction. How will you present if I put obstruction here, right? Of course, you're going to get distended. It's no brainer, right? Because there's obstruction, most of the fluid in your small bowel is green. You're going to have bilious. The obstruction above the area, the bowel above the obstruction, the sound is going to be high pitch. So this bowel, this here, high pitch sound, but the bowel that is below is going to be low pitch. So high pitch above and low pitch below. You also have to know most people who had previous surgery, they get a small bowel obstruction because there's adhesions. We already read from the case, colic abdominal pain is possible. And this is sudden onset. It's not gradual onset, it just happened. So these are all features of a small bowel obstruction. So you have to know the difference between a small bowel obstruction and a large bowel obstruction. So in order for you to distinguish, I give you what is the large bowel obstruction. So which of this is consistent with the large bowel obstruction? So tell me, give me your answer now. Which of the I've shown you the difference between large and small. Which of these should be consistent with a large bowel obstruction? So in a large bowel obstruction, it's a gradual onset. There will be no flatus of bowel movement. You don't need to have history of abdominal surgery. You get severe distension and then you are feculent. History of abdominal surgery is consistent with the small bowel obstruction. And in between them, there's something we call Ileus. For each finding below, specify if the finding is consistent with the Ileus. It's not a small bowel obstruction. It's not large bowel obstruction. It's not small bowel obstruction, but it's Ileus, right? Is he associated with recent abdominal surgery? You should say abdominal surgery, large bowel and small bowel dilatation, hyperactive bowel sound, gas in the bowel, small bowel and large bowel, maybe electrolyte induced or maybe medication induced. So this is another way you have to know the difference. This large bowel, small bowel, and Ileus. Ileus, basically what happened is it may be related to electrolyte problem because especially potassium, or you take some medication or the bowel slow down. Okay, you're going to see gas in both the large and small bowel. The bowel sound will be hypoactive. Okay, and the large bowel and small bowel will be dilated, unlike the bowel obstruction, small bowel obstruction. And they usually have recent surgery. So you just had surgery a few days ago, then everything slowed down. That is the difference between large bowel and small bowel obstruction. Okay. Now, a nurse has reviewed the clinical data. Which intervention the nurse should include in the plan of care? Now you should by now know what the patient is suffering from. So what are you going to do? Insert NG tube, insert rectal tube, prescribe enema or stimulant and laxative. Initiate low residue diet, strict bed rest, prescription for oral antiemetic or isotonic fluid resuscitation, or give them um, antibiotic. So this is the information, but you have to make a diagnosis. You see, I have not told you the diagnosis because I want you to figure it out yourself. If you know what this patient have, then how are you going to treat them? You put an NG tube in, you put a rectal tube, you give them enema, you give them a low residue diet, you let them remain at bed rest, you prescribe oral antiemetic, you give them isotonic fluid, or give them antibiotic. What do you think we should give to this patient? This is a case study with a lot of information, giving you everything. If they give you a question like that, either a small or large bowel obstruction or ileus, this is where they will take you. So how would you manage this patient? You have to know what the problem is. I'm not telling you. Um, you have to read the question. This is the question. And by now, I think you should figure out what the patient has. So what do you want to do? What do you want to do? The patient is vomiting. Of course, we're going to insert the NG2. The patient should get walk and make the bowel moving, so bed rest is not a good thing. So what else do you want to do for this patient? I can tell you the patient does not need antibiotic. There's no signs of infection. So what do you want to do? Of course, patient is NPO and NG tube. You're going to insect, um, give them IV fluid after we insect NG tube. We don't need to give the patient enema. We don't need to give the patient rectal tube. We should not give them enema because they are obstructed, right? So we can't give them enema to do that. No way. Enema is bad. When we insert NG tube, rectal tube is not indicated. They don't bring the NG tube, you cannot eat. So this has to make sense. If you have NG tube, why would they have to give the patient low residue diet? It does not make sense, right? Patients supposed to move to improve their bowel function. If the vomiting, I'm not going to give you oral antiemetic. You have to watch for all these important. This is what I call attention to detail and paying attention to details. And this is what I call the password. You see antiemetic and you pick it, but you forget that in front of it there's oral. You can't do that. She's vomiting. He or she is vomiting. You can't give them oral. Everything goes through the IV. So this was a trap question, and there's only two answers. You see, there's a bunch of them all the way to H. They don't need antibiotic. They just need a fluid and an NG tube. You don't need a rectal tube. You don't need a prescription for enema. They need to be NPO. They need to get out of bed and walk. They need IV antiemetic. Now, and let's review the client metabolic panel results. Which finding the nurse should anticipate? Select or apply. So you know what the patient is suffering from. Now we're getting a lab work, we're getting a basic metabolic panel. Which of these do you expect on your lab work? When you get the lab, which one do you think we should expect in the lab work? Tell me what you think. Fluid coming out is bilious. Is bilious, right? So yeah, this is everybody who is vomiting as NG tube. You get hypokalemic, right? Your potassium is going to go down. Your sodium goes down. Your chloride goes down. You have metabolic alkalosis, no acidosis, and so this is bicarb elevated. You should be able to like figure out this easily because you know patient is vomiting. So this is the key aspect of it. So we're going to see hypokalemia and elevated that. So these are the right answers. You're not going to see acidosis. If you get it wrong, you should check adapt thinkers and then watch some videos, or you can go anywhere you want, but just make sure you get the fact. This is straightforward. Anybody who is vomiting, get hypokalemic, hyponatremic, hypochloric, metabolic, alkalosis, not acidosis, and bicarb elevated is a form of metabolic alkalosis. So that's the lab work you should expect. And let's prepare equipment for insertion of NG tube. Which action by the nurse is appropriate? Select that apply. Ask client to extend neck backward during initial insertion. Mark the insertion tube so we can do both one at a time. We are going to place NG tube. Which of these processes is usually acceptable, right? Ask client to extend neck backward during initial insertion. This is what you tell the patient. When you're going to place the NG tube, you got to look backward first. So this is appropriate, right? This action is appropriate. When you set in NG tube, that's the first thing you tell the patient. Mark the insertion length with a small piece of tape. You should not mark the NG tube with any marker except small tape that you can take it out. So this is good. Measure and mark the tube from the tip of the nose to the stomach. What do you guys think? Who think this is appropriate or inappropriate? Measure and mark the tube from the tip of the nose to the stomach. So this is inappropriate. You don't mark from the tip of the nose to the from the tip of the nose to the stomach. So that's wrong. Ask clients to flex neck forward when above the oral pharynx. When you're above the oral pharynx, first you let them, their head is back. When you're above the oral pharynx, that means at the back of the throat, you let them flex the neck now to prevent aspiration, right? Mark and measure the from the tip of the nose to the earlobe to the xiphoid. We think this is appropriate. This is how you measure NG tube. Provide sips of water during insertion. Is this appropriate? When you insert in NG tube, you should give them water to drink. Small sips of water. Verify tube placement before removing the stylet. Of course, we're going to verify tube placement, but NG tube has no stylet. Okay? It has no stylet. It is not nasal, jejunal feeding tube. It's not a feeding tube. It has no stylet. We don't have a stylet. So this is a design as a trap to let people pick it. You put a verification, and so you go for it, but you don't read everything. NG tube does not have stylet. It's the content trapping question. But your anglers will do that because they just want to get you wrong sometimes. They want to see if you're paying attention. And so that one is not right. Next, wear a clean gloves and client is in semi-fowler position. Is that appropriate? Clients need to be in high fowler position, not a semi-fowler position. It's not a sterile process, so the next wear clean gloves. So that's fine. So have true answer choice, but the second one is wrong. So both answer choice is wrong. Have true answer is not the right answer. So this is a trap also. So like I said this question to make it hard. They are not interesting. GI case studies are not interesting, but that is the way it's designed. And next, plan to check tube placement. Which action is the best option? To check for tube placement, what do? Listen for the NG tube when you're instilling here. Get a gastric pH of 5.5. Check radiographic confirmation or measure the length of the tube. Which one is the best way to confirm placement? So the best confirmation is radiographic. pH of less than 5.5 is also good, right? Listening is not scientific. Measuring of the length is not accurate. These two are the best one, but radiographic examination, the one you can see with your eyes, is much better confirmation. So C is the right answer. And next, inserted the tube picture below and immediately received 500 ml bilious output. Which of the following the nurse should include in the plan of care? So we inserted this kind of tube. Look at it carefully. You see there's a blue cap here. You go here, and then this is where you go to the NG tube. This is go to the suction, and this go to the patient abdomen and into to the stomach. And you see the marking. So you have to know what kind of tube is that. It has the blue with the cap end, and then you have a suction end, and this is what goes into the patient stomach with the marking, usually close to 55, depending on how tall you are. Right. So the nurse has inserted this tube. You got to know how to manage it. What do? You document it as saline sample. And do you place the tube on the low, intermittent, or continuous suction? You check residue every 4 hours. Do you keep the air vent, that's the blue port, closed? Do you keep the client in the semi-fowler position? Provide oral care every 4 hours. inspect the drainage tube for patency, turn off the suction briefly to listen, flush the vent with air. Basically, it's content. This is like full NG tube content I'm trying to give you. That's why the case is long, but that's the way I try to do it. This is like giving you a lecture. So you have to know what kind of tube is this, and therefore you can know how to take care of it. I can tell you this is we call it SAMP tube because it make noise. Saline SAMP tube, it make noise. It's not a Levine tube. The Levine tube does not make noise. When you see 2N with the blue cap, yeah, that's saline SAMP. How do you insert the NG tube after insert it? What do you do? Is this right? Place the tube in a low, intermittent, or continuous action. Is that what you do? Yeah, it depends on the need of the NG tube. If you need to suck a lot of fluid, you can keep it in the low continuous action. But most NG tube are kept in the low intermittent because of the pressure to prevent gastric ulceration. So most of the time, so you can put it both ways depending on the condition. Check residue every 4 hours. What do you guys think? Give me an answer. Residues every 4 hours. You don't check residue every 4 hours. And this patient has small bowel obstruction. I've given you the answer. When we insert NG tube for decompression, there is no need to check for residue. Watch for this trap. It's a trap. It's designed for decompression. So no chest tube, no residue. Keep the air vent blue port closed like that. Keep the air vent blue port closed. What do you think? This port, they want you to keep it closed. Should be kept open. That is the why it's called saline SAMP. This, there should be no blue cap. You need to take it out. I know nurses try to put the cap there so that fluid does not leak. But when you cover it, there's no air going in, so it does not act like a saline SAMP. It's not whistling. Therefore, this is a wrong answer. It's a trap one. Keep client in a semi-filer is true. After you place the NG tube, you can keep them in the semi-filer. They need oral care every 4 hours. Okay. You need to check the tube for patency. So this is true. And then you can turn off the suction to listen. This is also true. If the tube is clogged with air, especially the blue tube with fluid, you can flush air through this and it push it back in. That's why it's called saline SAP. Therefore, this is true. You have to know this, all this information I put here. Every question they ask you, somebody has NG tube, they're going to ask you about checking residue. What do you do with the blue pot? What kind of tube is this? What kind of suction do you put it? Do you provide oral care? Which position do you keep the patient? You turn off the suction and listen and flush the tube with air if it's clogged. This is a classic NG tube question. And finally, client began passing gas and NG tube removed due to minimal output. Which of the following is appropriate? Now, patient is passing gas, no more obstructed. NG tube is minimal. We put it out. You want to start patient on regular diet. You want to keep the patient NPO. You want to start clear liquid diet. You want to discharge the client home. What would you do? Patient has bowel function, so we should start clear liquid diet. And this is the end of the case. We saw this patient, this 45-year-old, came to the emergency room, crampy, colicky, abdominal pain, vomiting for 2 days, nausea, decreased appetite, not passing gas, and stool. Was distended, had a previous surgery, so he has all the classic symptoms of small bowel obstruction because of previous surgery. Adhesion, abdomen is distended, We have hyperactive bowel sound. We place NG tube. We suction the patient. We know what kind of electrolytes we're supposed to. We know how to treat the patient, how to manage the NG tube, and what do you do when the NG tube come out, and what do you do with the patient. This is our Dr. class. You have a good day. If you want to join our class, we start today. It's not too late to register. Otherwise, good luck in your exam.